Dr. Mary, you may start.
Good morning. Welcome to the WHO Africa media briefing, which is taking place in collaboration with the APO group. I'm Dr. Mary Stephen. First, some housekeeping. You can listen to the press conference in French or English. To do this, please go to the globe icon on the bottom right-hand corner of your screen and select your most preferred language. Vincent, please, in French.
Bonjour à tous, vous pouvez suivre cette conférence de presse en français en cliquant sur l'icône interprétation en bas à droite de votre écran. Over to you, Dr.
Okay. Joining us all the way from Geneva is Dr. Mashidisha Moyeti, WHO Regional Director for Africa. I will now hand over to Dr. Moyeti to introduce our other panelists. Welcome, Dr. Moyeti.
Thank you very much, Mary. Good morning, good afternoon, bonjour, and welcome to all the journalists joining this press conference. Today, we'll discuss the recent decrease in COVID-19 cases in the African region, following a brief spike driven by a new wave in South Africa, as well as projections for the second half of 2022. We'll also discuss WHO support to African countries to strengthen monkeypox surveillance and response, following reports of cases in 7 countries on the continent since the beginning of the year. I'm pleased to be joined for this important conversation by infectious diseases epidemiologist Dr. Ifedayo Adetifa, the Director General at the Nigeria Center for Disease Control. Welcome, Dr. Adetifa. And Dr. Alouine Badr Ali, Director of Health Emergency Operations Center in Senegal's Ministry of Health and Social Action. Bienvenue. A very warm welcome indeed to both of you. There have now been 11.9 million COVID-19 cases and 253,900 or so lives reportedly lost in Africa due to the pandemic. Looking ahead to the second half of 2022, I'm pleased to share the new WHO modeling that suggests we're turning the tide on last year's catastrophically high COVID-19 death toll in the African region. As I've said previously, the reported deaths are also only about 1/3 of what we estimate as the true burden. In 2021, the pandemic took reportedly as many as 970 lives every day. The new analysis anticipates a decline of almost 94% in that number for the region by the end of 2022 to about 60 deaths daily. While the advances in reducing death rates is a huge achievement and testament to the unwavering efforts of countries and partners, that number is still unacceptably high. To maintain this lower number, it'll be crucial for African countries to focus on protecting those populations at highest risk of severe COVID-19 disease and of dying. These include people older than 65 years and those with underlying illnesses such as heart disease, diabetes, cancer, and untreated HIV. Current data from 32 countries in the region shows improved coverage among these target populations, 29% of median coverage compared to 19% for the general population. Among the 5 countries that have fully vaccinated more than 70% of their target populations, Mozambique is the highest at 93%, followed by Botswana at 89% and Mauritius at 80%. Lowest in the region is the Democratic Republic of the Congo, which has fully vaccinated only 6% of its target population. Madagascar and Malawi have fully vaccinated 8% and 12% of their target populations, respectively. We've learned many lessons in how to stay a step ahead of the virus, and now it's time to refine our response. Countries must intensify efforts towards a targeted response that provides the most vulnerable with the health services that they need, including COVID-19 vaccines and effective treatment. Targeted surveillance also remains critical to monitor hospitalizations, the burden of comorbidities, deaths, and very importantly, the emergence of new variants. The analysis published in the Lancet Global Health Science Journal this week forecasts that COVID-19 related deaths will drop to 23,000 for the African region by the end of the year, compared to 113,000 or so last year. But it also warns that a variant 200% more lethal than those already experienced has the capacity to rapidly more than double that number. Additionally, the divergent death rates between countries in the region emphasize the need for tailored responses. For example, high and upper middle income countries across the region, along with those in Southern Africa, are recording death rates twice as high as those of their lower and lower middle income counterparts. According to the study, this variation is driven primarily by comorbidities. In our countries with higher rates of hypertension, diabetes, chronic obstructive pulmonary disease, HIV, and obesity, death tolls from COVID-19 are also higher. As the pandemic persists, what is clear is that our actions need to keep pace with what remains an evolving and complex situation. Turning now to the monkeypox challenge, I can confirm that since the beginning of 2022, cases have been reported in Africa from Cameroon, the Central African Republic, the Republic of the Congo, the Democratic Republic of the Congo, Liberia, Nigeria, and Sierra Leone. WHO and partners are joining forces to urgently understand the magnitude and cause of the global outbreak. So far, reported cases have no established travel links to endemic areas. Based on currently available information, they've mainly, but not exclusively, been identified amongst men who have sex with men seeking care in primary care and sexual health clinics. What is extremely important now is to avert any potential for a repeat of the inequitable access to COVID-19 vaccines experienced by African countries early in the pandemic. We must have one connected global response to monkeypox to avoid it becoming endemic in more countries. This requires equitable access to the necessary tools and resources and information exchange to promote understanding of the depth of the challenge. Parts of Africa may well have built up some immunity to monkeypox, but equal access to effective vaccines is critical to protect the continent's particularly vulnerable populations, including health workers and the context of cases. As WHO in the African region, we are working closely with African governments, regional institutions, and technical and financial partners to bolster laboratory diagnosis, disease surveillance, readiness, and response actions to curb further spread of the virus. We're also providing expertise in the form of vital technical guidance on testing, clinical care, preventing and controlling infections, along with how to inform and educate the public about monkeypox and its risks. As is the case for COVID-19, collaboration with communities is integral to disease control efforts. Africa has successfully contained monkeypox outbreaks in the past, and from what we know about the virus, the modes of transmission, the rise in cases can be stopped. I look forward very much to our discussions today, and thank you again for having joined us.
Dr. Stephen, you're on mute.
Etifa, can you please tell us how Nigeria manages monkeypox outbreak?
Well, good morning, RD and colleagues, gentlemen of the press. Thank you very much for the opportunity to be here, and thanks for your question. Well, as the RD earlier highlighted, Nigeria, along with a few other countries in Western and Central Africa, have had sporadic or indeed large outbreaks of monkeypox. The history of monkeypox in Nigeria is that the first case was reported in 1971, shortly after a discovery in the DRC. Sporadic incidences were seen between 1971 and 1978, and then there were no cases for 40 years until monkeypox reappeared or re-emerged in 2017 in what was what has been the largest outbreak in Nigeria so far. Since this time, we've, of course, monkeypox is a priority disease for surveillance, given its prioritization by WHO and member states, given its epidemic potential and, of course, its relationship with smallpox, which has not been eliminated. So we've had in place surveillance to and introduce diagnostic capacity to ensure that we can, we moved away from the situation where when it first re-emerged, we were dependent on external collaborators and parties for support, for diagnosis and for sequencing. But we put surveillance in place and we since then have been able to record cases of monkeypox, few numbers here and there since 2017, and we continue to do so till date. We've also domesticated sequencing capacity for monkeypox and are able to conduct our own sequencing now for monkeypox. We've got a technical working group for monkeypox at the Nigerian Center for Disease Control who have managed the response in terms of ensuring that there's investigation of all suspected cases and confirmation of diagnosis.
Dr. Adetifa? Okay, it looks like he has challenges with internet. So let me turn to Dr. Lee, and then I'll come back to Dr. Adetifa when he connects back. Dr. Lee, please, could you discuss how Senegal has adapted its COVID-19 response during the past 2 years?
Oui, je vous remercie, Madame la modératrice. Permettez-moi de transmettre mes cordiales salutations à Madame la directrice régionale de l'OMS Afro et mes salutations également au docteur Idefayo Adetifa. Pour aborder la question de la façon dont le Sénégal a géré la COVID-19, je dois commencer par rappeler que le premier cas enregistré au niveau de notre pays remonte donc au 2 mars 2020. Et dès le 3 mars, le centre des opérations d'urgence sanitaire que j'ai l'honneur de diriger a été activé par l'ordre de Monsieur le ministre de la Santé et de l'Action sociale. Et un système de gestion de l'incident a tout de suite été mis en place, dirigé par un SDAN manager qui se trouve être justement le directeur du centre des opérations d'urgence sanitaire. Et depuis lors, donc cet AMS, cet SDAN Management System, donc, a été mis en place et a monitoré, a surveillé de manière quotidienne l'évolution de la pandémie au niveau de notre pays. Et bien entendu, sur la base de l'évolution de l'épidémie, les procédures opérationnelles normalisées qui ont été mises en place ont dû être adaptées en fonction justement du profil épidémiologique. Je dois rappeler aussi que la pandémie a évolué d'une manière générale en 4 vagues au niveau du Sénégal. La première vague avait été liée à la souche originelle, la souche sauvage, la souche de Wuhan. On est passé après à une deuxième vague qui a été plutôt liée au variant alpha et suivi du 3e lié au variant delta. C'est le variant delta vraiment qui a soumis notre pays en fin 2021 vraiment à une position extrêmement importante sur le système de santé, du fait justement du nombre de cas extrêmement important, mais aussi du nombre de cas graves, et donc la pression sur le système de santé et sur nos capacités justement de prendre en charge justement ces cas graves qui étaient compliqués, souvent de problèmes respiratoires et qui avaient nécessité des quantités extrêmement importantes d'oxygène. Et à un moment donné, d'ailleurs, cet intrant était devenu vraiment capital dans la stratégie de riposte de notre pays. Ensuite, il y a eu une quatrième vague qui était liée au variant Omicron. Et cette quatrième vague, aujourd'hui, elle est finissante. Donc, pratiquement depuis le début de l'année, depuis la deuxième semaine du mois de janvier, nous sommes dans une phase de baisse progressive donc, qui se consolide. Et jusqu'à maintenant, celle-ci se traduit pratiquement par environ, on décompte, par moins de 50 cas par semaine, des cas confirmés par RT-PCR. Et au moment où je vous parle d'ailleurs, depuis une quarantaine de jours, nous n'avons pas un seul cas grave donc, dans nos CTE, dans nos centres de traitement des épidémies. Et depuis le 14 mars 2022, nous n'avons eu à enregistrer que 2 décès. Et depuis 5 semaines, nous n'avons pas eu de décès liés à la COVID. Et donc, les stratégies qui ont été mises en place donc, à travers, pilotées par l'Incident Management System au niveau du centre des opérations d'urgence sanitaire, ces stratégies ont été des stratégies évolutives. Donc, nous avons dû les adapter progressivement en fonction, donc, je le disais tantôt, du profil épidémiologique, mais en fonction aussi des nouvelles connaissances. Et aussi en fonction aussi des recommandations donc, que nous recevions de l'Organisation mondiale de la santé. Ceci nous a permis de mettre à jour l'ensemble de nos procédures qui portaient sur disons, les interventions majeures en termes de coordination, en termes de gestion des cas, en termes de surveillance, y compris la surveillance génomique avec les laboratoires, en termes aussi de gestion aussi de nos points d'entrée, de la vaccination, etc. Donc, l'ensemble des interventions clés ont fait l'objet tout au long donc, de la pandémie, donc d'adaptation pour permettre à notre pays de ne pas, en tout cas, être dépassé par la pandémie. Je dois dire aussi, et je pense que c'est important que nous avons pu bénéficier au niveau de notre pays d'un fort leadership, donc représenté par le président de la République lui-même qui s'est très tôt engagé et a pris, comme à l'instar d'autres pays, des mesures fortes donc, de contention de la pandémie. Alors, présentement, donc, la question qui se pose pour nous, ça fait vraiment, depuis le début de l'année, on est vraiment la situation est très calme, aussi bien au niveau de Dakar qu'au niveau de l'ensemble des 13 autres régions où il n'y a pas de cas, il n'y a pas de malades actuellement au niveau de nos CTE qui ont donc dû être, disons, désactivés, puisque ces centres-là sont des centres normalement qui sont dédiés à d'autres fonctions, c'est d'autres services que nous avons dû utiliser face à l'urgence donc pour en faire des CTE. En termes de projection, aujourd'hui, nous avons essayé de travailler avec les collègues biostatisticiens de l'Institut Pasteur de Dakar qui avaient prédit la quatrième vague et qui l'avaient fort bien prédit d'ailleurs. Et aujourd'hui, nous pensons qu'en l'absence, en tout cas, d'apparition de nouveaux variants et que si toujours nous avons au niveau de notre pays le variant Omicron qui continue de circuler, et si on tient compte aussi de la période d'efficacité de l'immunité de groupe, donc objectivé en tout cas par rapport à la dernière enquête de séroprévalence que nous avions eue, qui donnait un taux de séroprévalence de 90% en moyenne. Nous pensons que, en tout cas, selon les modèles que nous avons mis en place avec donc, les collègues de Pasteur, qu'on devrait avoir, il est possible qu'on ait en tout cas une 5e vague, donc une légère remontée des cas, donc vers la fin juillet, août 2022, si on tient compte de la période d'efficacité de 6 mois donc de l'immunité. Donc voilà, donc si vraiment on a une 5e vague inférieure à la 4e vague qui pour l'essentiel a été constituée par des voyageurs, donc 95% des tests qui ont été effectués chez des voyageurs, 65% des tests positifs c'est des voyageurs, donc des personnes asymptomatiques. On a eu très peu de cas suspects, très peu de contacts. Donc si cette prédiction se confirme, c'est plutôt rassurant pour nous, même si effectivement nous avons un taux de couverture vaccinale qui reste assez faible. 16% de personnes de la population cible de plus de 18 ans qui ont reçu une dose et disons 12% donc qui ont reçu 16% qui ont reçu une dose et 12% qui sont complètement vaccinés. Voilà ce que je voulais dire, Madame la modératrice, en termes d'introduction par rapport justement à la façon dont le Sénégal a géré la COVID-19 jusqu'à maintenant. Je vous remercie.
Merci beaucoup, Dr. Lee. And back to you, Dr. Adetifa, to continue with your intervention.
All right, I'm sorry, I'm not sure what happened to the connection, and I'm not sure at what point you lost me, but I was trying to explain that following the 2017 uptick or outbreak or reemergence of smallpox in the country, one of the things that we put in place immediately was to scale up the deployment of our national digital surveillance system that provides a real-time reporting of diseases of interest, of which monkeypox was one. And that, of course, provided quite, was a useful tool in making us understand very quickly what was going on and, of course, enhanced reporting. And since the rollout of the mobile digital surveillance outbreak response and management and analysis system, which we call SOMAS, this has been scaled up across the countries, deployed in all states, including the federal capital, and in all local governments. And at the moment, we are working on actually deploying this to cover all of the health facilities as well, just to ensure, not just for monkeypox, but we have national cover in terms of real-time surveillance for diseases of interest, including smallpox, and it is including monkeypox, and it's this system that is allowing us, or that has enhanced our ability to continue to report on monkeypox cases since 2017 when it re-emerged. I'm not sure if you also had the part where I talked about our putting into place, of course, laboratory capacity for diagnosis and laboratory capacity for sequencing in the aftermath of 2017. So in the early period, we were dependent on collaborators and partner countries to diagnose monkeypox and to sequence it, but all of this capacity is now domesticated. So thank you very much.
Thank you, Dr. Adetifa. Yes, Nigeria has definitely come a long way in dealing with monkeypox outbreak. So thank you for sharing your experience. And now that you have heard from all our speakers, it is your time, journalists, to ask your questions. To do this, please use the Q&A function on the Zoom platform. Tell us your name, the name of the media organization you represent. And if you like to go live, please let us know to the Q&A as well. We have additional experts that will answer your questions today, and they include Dr. Humphrey Karamagi, the Senior Technical Officer for Health System Development here at the Regional Office, Dr. Fiona Baraka, Team Lead for Emergency Response, Dr. Meseret, WHO Immunization Officer, Dr. Tiano Balde, our COVID-19 Incident Manager, and Dr. Frank Mbusu, COVID-19 Vaccination Monitoring and Evaluation Lead. Vincent, can you please explain to our French-speaking audience?
Pour poser vos questions, nous vous demandons d'utiliser la fonction questions-réponses qui est en bas à droite de votre écran et de bien préciser votre nom et votre média de façon à ce que nous puissions prendre votre question en compte. Pensez que nous avons aussi à disposition d'autres experts du bureau régional de l'OMS qui sont donc là pour répondre à vos questions. Merci beaucoup.
Merci, Vincent. So the first question is coming from Alan from BBC. Are you there, Alan?
Yes, I am. Thank you very much for the opportunity to ask this question. And I'd like to ask Dr. Moyeti, first of all, from everything I've read, there is no connection between the breakout or the outbreak in Africa and what's happening in the other parts of the world. So why are we talking about this now? Why is it becoming a big deal in Africa, yet Africa has been dealing with it for a long time? Is it because it's suddenly happening in the West that voices are being raised? And then also, from what I've read, it seems like the availability of vaccines has been around for a while. It seems to me from reading that the US and the United Kingdom, the UK has been immunizing people who are at risk, and there's been all sorts of measures taking place in the West to contain the spread of monkeypox. I wonder if that points to what we've been seeing with the COVID vaccine as well, where the West has all these interventions, it has all these things, possibly vaccines, but they're not available to Africans. Is this the case? Thank you.
Thank you, Alan. Dr. Moyeti, you can go first, and Dr. Fiona could prepare to weigh in.
Okay, thank you very much for that, for those questions. First, the connection between the cases arising in now a number of Western countries mainly and African countries. I believe there was one connection, I may be wrong, with travel from Nigeria. It may be that I'm mistaken, but in general, this outbreak seems to have started from people who were together in Spain and then has spread very quickly to a number of first European and then a number of Western countries. So I think this is an unusual phenomenon, and the way the world is connected, we need to be concerned when we observe a phenomenon of this nature. The rate at which the cases have spread geographically has been extremely rapid, and there is concern to understand what is happening exactly with these cases, which looks to be also different from the general pattern of transmission that we have seen in African countries. So I think it must be a big deal for everybody in the world. We in Africa will also like to understand, because we need to have a connected global response to this situation so that we benefit from any new knowledge or information that may be arising from what is happening here, and we anticipate and see how it might be applicable to the situation here in Africa. So that's what I would like to say in terms of why is it a big deal now. And as our colleague from Nigeria explained, there were quite a few years between the initial appearance of monkeypox in Nigeria and then the outbreak in 2017. And then after that, we've seen cases happening regularly and in a number of countries in both Central and West Africa. So we should always be concerned, try to know what's happening, try to anticipate what would happen with a view to being able to control the situation. I'll hand over now to my colleague to respond and perhaps also to provide information about availability of the vaccine. I think just looking forward, I can say in principle, we would like every tool that is available to be deployed in Africa as is happening in other countries, of course, so that we don't have an inequitable situation either continuing or being exacerbated. Fiona, over to you.
Thank you, Dr. Moyeti.
Thank you, Dr. Moyeti, and thank you, Alan, for that question. Just to add to Dr. Moyeti's submission, there have been outbreaks of monkeypox that were reported outside Africa, dating back to 2003. There was an outbreak that happened in the United States. We had over 70 cases that were reported there. There have been small outbreaks in Israel, in Singapore, and even in the United Kingdom. So it's not the first time that there have been incidents of cases outside the typically endemic countries in Africa. The atypical nature currently is that we are seeing large number of human-to-human transmission outside endemic countries, but also affecting this group of population that has not typically been seen before. It's a lot of information that needs to be analyzed to determine the chains of transmission, and that is what WHO is currently working on with a group of experts, and again calling for collaboration between continents to really get to understand this disease more. On the subject of vaccines, currently there are very limited quantities of vaccine available. As you may know, a smallpox vaccine, smallpox having been eradicated, that vaccine has shown to be effective against monkeypox. But since the disease was declared eradicated, there've only been small quantities that have been prepositioned as national stockpiles in a few countries. And recently, we now have a new generation vaccine against both smallpox and monkeypox that has been approved, but it's also not widely available outside the national stockpiles that we know of. So WHO is convening vaccine and immunization experts to review the existing evidence around vaccines, also to understand the quantities that are available in the national stockpiles, and to make recommendations for their wider use. There's going to be a need to ramp up the availability of vaccines, but currently they are not available in large quantities. And the recommendation currently is to target very high risk groups, those that have had physical contact or at risk of contact with confirmed cases. So it remains a very limited use for the vaccines at the moment.
Right. Thank you very much for that very comprehensive answer, Fiona Bracker, who is my friend of almost 30 years. But if I may just go back to Dr. Moyeti, how would you say, when you take a look across Africa, how much of a public health priority is monkeypox for Africa?
I mean, so monkeypox is endemic in a number of countries, and those are countries that have other outbreaks as well. I think what we've heard about the experience of Nigeria shows that it has been a priority in Nigeria. They've taken concerted steps to build their capacity for surveillance, for sequencing, and for response to monkeypox. Overall, it is not endemic in a large number of countries in Africa. You know, we have diseases like HIV. We have other diseases that are much more common on the continent. I think what we can say is that we are learning about the potential for monkeypox to spread from this particular experience in the West. And we are now in the region looking at ensuring that we support our countries in a much more concerted way in anticipation of what might happen and as part of the learning of this situation here.
Thank you very much, Dr. Moyeti and Dr. Fiona, for those answers. Our next question is from Elise from Le Monde, and the question is coming to you, Dr. Adetifa. How can you ensure the rise of monkeypox infections how can you explain actually the rise of monkeypox infections in Nigeria in 2017?
Thank you very much for that question. I think the short answer is we don't know. Nobody knows. There's been quite a significant discussion around the reemergence of monkeypox, both here in Nigeria and specifically in the UK. I remember there was a Chatham House discussion with experts. So the leading hypothesis for that is reducing population immunity to smallpox, given that of course, the smallpox viral vaccination program was discontinued once eradication was achieved. And what that usually means for populations for any disease is that as people are born and there are new people entering a population and exiting, ultimately, without continued exposure to the pathogen targeted, you will have reduction in immunity. And what then happens is in the case of smallpox, the hypothesis is perhaps given that monkeypox is a relation or distant cousin, depending on how you define it, monkeypox may step into the space that has been vacated by smallpox, and perhaps this is already what we are seeing. Again, speaking hypothetically, it's also assumed that part of the reason why we haven't really seen that kind of expected increase as you would get if you had true replacement of smallpox in its ecological niches, that monkeypox itself is not as good as smallpox or as efficient as smallpox, as the smallpox virus in person-to-person transmission. So you have the initial spillover events from whatever reservoir, animal reservoir, the initial infection is obtained from, and then you have limited human-to-human transmission. And because it's not really efficient, you then also have a bit of time to put in place interventions to bring particular outbreaks under control. So this is hypothetical. This is the thinking of people. As far as Nigeria is concerned, we've basically tried to understand if anything has changed, or really which animal is the reservoir for monkeypox virus, or which range of animals are reservoirs for monkeypox virus, and how does transmission, at what point do you have the spillovers, and what can we do to intervene and prevent that from happening? The interesting thing is working with partners and looking at some of our preliminary results, we still haven't, despite in the last round, looking at over 240 different animals, different rodents, monkeys, and all of that. We still haven't actually identified monkeypox itself in any of the potential animal reservoirs. What we know for preliminary results is that the family of viruses, the orthopox viruses, we do have evidence that they appear to be circulating in some of these animals that were expected to be monkeypox reservoirs. So I think the lesson for all of us, and which is why monkeypox was already listed as a condition of priority by WHO, is that we need to keep an eye on these zoonotic illnesses or zoonotic pathogens. They are going to be responsible for an increasing number of outbreaks in the human population, especially as the animal-human interface continues to be narrow.
Exactly.
Thank you.
Yeah.
Thank you, Dr. Adetifa. Yes, imagine and reimagine infectious diseases continue to pose public health risks to our world today. So we need to make sure that we are prepared at all times. The next question is coming from Dio from Radio Osiyun speaking in Senegal. And this question is coming to you, Dr. Lee. What strategies is Senegal implementing to boost COVID vaccines, given some reluctancy from the youth? And Senegal has committed to manufacturing vaccine. Where are we now? Over to you, Dr. Lee.
Oui, je vous remercie, Madame la modératrice. C'est vrai que la question de la vaccination, c'est une préoccupation que nous avons devant la faiblesse, disons, de la demande, justement, venant des populations pour être vaccinées. C'est un constat que nous faisons. Nous avons essayé de réfléchir pour comprendre les motivations, les tenants et les aboutissants, justement, de ce manque, disons, d'adhésion des populations au programme de vaccination contre la COVID. La seule fois où on a vu un rush, disons, des populations vers les centres de vaccination, c'est pendant, comme je le disais dans mon introduction, pendant qu'on avait la troisième vague liée au Delta. Effectivement, il y avait une perception du risque, certainement très élevée au niveau des populations, parce qu'il y avait beaucoup de cas graves, beaucoup de décès. Et en ce moment-là, effectivement, il y avait un engouement donc, manifeste par rapport donc, à la vaccination. Mais dès que la tendance s'est inversée et que le nombre de cas a commencé à baisser, bien entendu, du coup, il n'y avait plus cette adhésion qu'on avait notée avait baissé. Et il y a des facteurs aussi un peu intercurrents, j'allais dire, parce que ça correspondait aussi, cette forte demande a malheureusement entraîné aussi pendant une certaine période une rupture de vaccin. Et ça a peut-être contribué aussi au découragement que nous avons pu noter. Alors maintenant, la stratégie que nous sommes en train de faire, justement, en perspective, justement, comme vous le dites, hein, le Sénégal qui s'est positionné avec d'autres pays pour la fabrication de vaccins, avec donc, justement l'Institut Pasteur, appuyé par beaucoup de partenaires, et avec l'OMS en particulier. Nous sommes en train de travailler là-dessus. Donc, les réformes administratives pour atteindre le niveau de maturité 3 que l'OMS nous exige, nous sommes en train de travailler là-dessus. Mais en attendant, pour amener les populations à la vaccination, ce que nous sommes en train de faire, c'est de travailler sur des plans de relance de la vaccination. Et ces plans de relance de la vaccination, ce que nous souhaitons faire, c'est que ces plans de relance soient portés par les districts sanitaires, qui sont les entités opérationnelles du système de santé, et que ces plans de relance soient donc adossés à une forte campagne de vaccination, de communication, plutôt de communication de proximité. C'est ce que nous sommes en train de faire. Et aussi, surtout, renforcer la communication digitale, parce que c'est au niveau des réseaux sociaux, comme nous savons tous, que le mal, en tout cas, est fait en grande partie avec tout ce qui est message lancé par les anti-vaccins, etc., tout ce qui est théorie complotiste, qui effectivement ont fait beaucoup de mal et ont fait en sorte que beaucoup de personnes aujourd'hui hésitent à prendre la dose de vaccin. Bien entendu, ceci est renforcé par la situation épidémiologique. Les gens disons, il n'y a pas d'engouement. On ne voit pas de raison à se faire vacciner dans un contexte épidémiologique où, effectivement, dans les bulletins que nous communiquons, nous, à travers les médias, il y a plusieurs jours où on déclare 0 cas, 0 cas, 0 cas. Et donc, du coup, les gens ne comprennent pas pourquoi, avec tout ce qui est dit sur les vaccins, ils prendraient, entre guillemets, le risque, justement, d'aller se faire vacciner. Mais aujourd'hui, nous avons le support de beaucoup de partenaires, l'OMS en particulier, la Banque mondiale, qui ont justement appuyé ces plans de relance de la vaccination. Nous allons probablement vers une grosse rencontre au niveau de notre pays avec l'ensemble des intervenants pour mieux réfléchir, mieux affiner justement les stratégies sur lesquelles on va s'appuyer pour essayer, en tout cas, d'inverser la tendance et amener effectivement les populations à adhérer à la vaccination. Et comme on le dit, hein, comme le disent les militaires, c'est pendant ces périodes d'accalmie qu'il faut mettre l'accent et qu'il faut peut-être préparer effectivement l'éventualité d'une 5e vague ou d'une 6e vague, en tout cas d'une vague qui pourrait être potentiellement beaucoup plus dangereuse que ce que nous avons connu jusqu'à présent. Donc, nous y travaillons avec la direction qui est en charge de l'immunisation, la direction de la prévention. Nous allons vers une rencontre élargie avec l'ensemble des partenaires, l'ensemble des acteurs du système pour justement réfléchir sur comment justement argumenter ces plans de relance au niveau du cycle sanitaire, mais aussi au niveau national. Déjà, la campagne de communication digitale donc, a commencé. Si vous regardez les réseaux sociaux, il y a beaucoup de spots, beaucoup d'affiches, beaucoup de messages qui sont lancés à travers donc, les réseaux sociaux. On espère que ça donnera des résultats. En tout cas, les vaccins sont là, sont disponibles, mais effectivement, jusqu'à maintenant, on constate qu'il y a une faiblesse de la demande donc, de l'offre de vaccination. En fait, la demande de vaccination venant des populations. Je vous remercie.
Merci, Dr. Lee. Thank you for sharing that experience from Senegal dealing with reluctance to take COVID-19 vaccine among the youths. Paul from the Lancet, are you ready to ask your question live?
Yes, I'm ready. Thank you very much. And so I'd like to start with Dr. Moyeti. So since this attention to monkeypox outbreak has begun now, I went to NCDC's database, and the center has truly been reporting these diseases, not just in the last 2 years alone. But my concern is this, considering the number, as these diseases reached an outbreak status level that warrant Africa to aggressively do something about it, and if this is the case, how can we ensure that Africa's public health actions are not largely driven by developments outside the continent, such that as the country is trying to control COVID, attention is being drawn to monkeypox. If a neglected tropical disease happens elsewhere, attention can also go to that. How can we ensure that priority to is given to, in terms of Africa's public health response, is given to what the country needs is actually a top priority. And looking at the development of vaccines, considering the fact that Africa now has vaccines coming out from different parts of the world, and scientific validation has come regarding the fact that there is winning immunity among the African population to smallpox vaccine. Is it possible for Africa's vaccine manufacturing ecosystem to prioritize production of smallpox vaccine, considering there seems to be the need for the vaccine presently? Thank you very much.
Okay, thank you. Yeah, thank you very much. I have to say you were speaking very softly towards the end, fading away. I was having difficulty in hearing your second question, the last part of your second question. Can I ask you please to repeat it so I know exactly what I'm responding to? Sorry about that. Our colleague from the line.
Okay. Yes, yeah. The last part has to do with Africa making a decision on smallpox vaccine. Is the evidence, considering there is winning immunity, does it justify Africa rolling out smallpox vaccines? And can available vaccine manufacturing capacity on the country be encouraged to pivot to producing these kinds of vaccines?
Okay. Thank you very much for those questions. I think your first question essentially is alluding to possibly distracting attention from other public health priorities, including the COVID-19 pandemic, for the fact that there are monkeypox cases in other parts of the world from Africa. I think our colleague has already said, and as I said before, we are seeing a slightly new phenomenon. There has certainly been an increase in cases in one country, Nigeria, after a long gap. So I think it's important for us to be on the alert, to learn as much as possible with the rest of the world, and to prepare ourselves to respond to any increase in cases that might occur in Africa, while continuing to pay the required attention to other priorities, such as you rightly have said, continue to vaccinate African people, particularly the most vulnerable groups of African people, against the COVID-19 pandemic, and responding to the many other outbreaks that we experience on the African continent. You know, we support our member states to respond to more than 100 outbreaks in a year of different levels of severity in Africa. So this is something where countries have to at the same time be responding to a cholera outbreak, the outbreak of COVID-19, other diseases as well at the same time. And I think our challenge is to build up the capacity in the countries to be able to do that to a degree that's required. And then the question of Africa producing its own vaccines and what are the implications for smallpox vaccine production? I think, again, we will be working with member states to study the evolution of this monkeypox outbreak in the African region, and to anticipate what might happen. There is a big, intense dynamic happening around local manufacturing of vaccines in Africa, which is a very good thing, which is one of the best outcomes of the COVID-19 pandemic, that the wish to have the capacity to do this has really translated in the context of this global crisis into action, investment by partners, by African countries, and decision-making at the highest level to produce vaccines that are needed on the African continent. And we anticipate that this will be the case not only for COVID-19, that would really be an investment in an issue for which the world is also in action, but to look at all the vaccines that are needed in Africa going forward, including the childhood vaccines and other vaccines that might then more appropriately be produced in Africa. I think that will require exploration, investment, training, and partnership at the global level in order to make sure that African people have access in a timely manner as to contain outbreaks before they turn into crisis of the tools that they need, particularly vaccines. So I think that's been a very positive development, and we need to look at it broadly, going beyond COVID-19 vaccines, going into the future as well.
Thank you, Dr. Moyeti. And the next question is from Thomas from DW News. This question is coming to you again, Dr. Adetifa. How is Nigeria conducting the testing strategy regarding monkeypox in the country, especially the surveillance of the current outbreak? And the second question is about the risks of monkeypox virus mutating to eventually become a real public health threat. Over to you, Dr. Adetifa.
Well, thank you for that question. Again, some of the points have been mentioned about, this renewed attention as a result of cases occurring elsewhere, either affecting our priorities in terms of our response to other conditions, knowing that we have sort of limited or finite resources that are all being competed for by varying priorities. But I think it's important that I highlight that we have always considered monkeypox important. We've always responded to monkeypox or conducted surveillance for monkeypox in Nigeria, even when it was not the sort of sexy topic on the headlines. So the headlines regarding disease conditions or outbreaks do not reflect priorities for national public health institutes. We continue to deal with everything: Lassa fever, cholera, measles outbreaks, yellow fever, monkeypox, COVID, as the case requires, regardless of what the headlines are focused on. So as I've said, we've had surveillance in place since 2017. We've conducted risk assessments every year to determine sort of the level of alertness or that we need to reach to manage the monkeypox cases as they arise. And so far for this year, we've conducted a risk assessment given the number of cases that we have seen, and we have now triggered a level of alert at 2, which is just before sort of you declare a full emergency. And we currently have an emergency operations center activated for coordination of the response to monkeypox. We have to increase I think part of the challenge with monkeypox in our context is the low risk perception. And I believe or hypothesize that a lot of chickenpox in adults probably were monkeypox cases, but because this is a self-limiting rash-associated illness, nothing untoward was considered to be happening. So we have sent out advisories, we have conducted and are planning to also even scale up awareness training for both health professionals and others. We have, of course, alerted our subnational colleagues to conduct awareness training and to work with people who work very closely with animals, so the hunters, the sellers, and people who work in abattoirs. The hospital management have all received advisories to encourage their teams to be increase their index of clinical suspicion, because that's what we really need. Any case or suspected case that is reported will be subjected to confirmation of diagnosis. So what we are focusing our effort on now at the moment is to address any possible underreporting that may be going on, so that we can confirm those cases and, of course, institute the appropriate public health interventions. In terms of the latter part of the question, as I've said elsewhere, for these pathogens, we have to remember it's a matter of survival. Just like we humans are getting on with life, earning a living, trying to survive despite everything that is going on, the pathogens are trying to do the same thing. So we do not, for pathogens that have the capacity to jump between animals and humans, there is no, there's always the possibility that they can adapt to human infection and become very good at it, which is what you are asking. But at the moment, we do not know. This is the subject of a lot of, especially genomic studies. People are looking at the changes in the genetic makeup of the pathogen to see if any of those changes may suggest an increased ability or increased efficiency to achieve human-to-human transmission. This is still ongoing work, and I think the short answer to that second part of your question is that we don't know. It's a subject of ongoing research, but it's theoretically possible. Back to you.
Thank you. Thank you, Dr. Adetifa. The next question is coming to you, Dr. Moyeti. This question is from Nimi from CNN. Is WHO investigating the request from Russia to investigate US-funded laboratories in Nigeria?
So, thank you for that question. I think, first of all, we are aware of media reports on this question. We are not aware of WHO having received any request from the Russian government to investigate monkeypox and other laboratories in Nigeria. I think what we can say, though, is that the US institutions, together with other partners, international partners, some countries in the European Union, for example, and other partners, have really supported the building up of capacity in the laboratories in the African region. I think the amount of support that has come to our region, particularly in the context of the COVID-19 pandemic, has been tremendous. So there have been partnerships to improve the capacity, to do the training, to improve the human resources in laboratory capacity in the region. And this we can only appreciate and applaud and expect it to be managed by the governments who are working in partnership with these other countries to ensure that what is carried out on their territories is carried out safely in a way that will not provide risk. I think we can only have learned from the pandemic of the need for these partnerships, of the capacities on the continent to be improved. And I think from both of these countries that are with us today, from Nigeria and from Senegal, these are countries that have leveraged partnerships to improve their capacity. So I can only conclude by saying so far as I know, we have not received such a request from Russia. And I'm certain if and when it is received, it will be given its proper attention. Thank you.
Thank you, Dr. Moyeti. And this question is coming to Dr. Fiona Braka. Which countries in Southern Africa are more exposed to monkeypox, and what should be done there? The question is coming from Columbus, from VOA. Dr. Fiona, please.
Thank you for that question. Just to say that primarily monkeypox has occurred in West and Central Africa, often in proximity to tropical rainforest. And we've started to see it increasingly appear in urban areas. Given the mode of transmission, which is a close physical contact with infected persons, the virus can infect anyone. So it's important that all countries are alerted and that they strengthen their preparedness to be able to detect and respond to suspect cases timely. We currently do not have reports of suspect cases from Southern Africa. We only have reports from 7 countries as of 2022, mostly in West and Central Africa. What can African countries do? Preparedness is important. We need to have strong surveillance in place, ensuring that the health workers in the front line understand the typical symptoms and are on alert to rapidly investigate any suspect cases. We know that disease presents in a similar way to other diseases like chickenpox. So it's important that there is an understanding of what a suspect case for monkeypox would be. We need to work on laboratory capacities in the countries. We have at least 10 countries with capacity for testing, and this number we hope will increase in the region. And the work around accurate information, ensuring the general public is sensitized and able to report or present or seek care once a suspect case is there is important. How we engage communities to ensure there is no stigma around the disease. All these are important aspects in a comprehensive manner. And finally, I think the work around ensuring the linkages, the One Health approach, trying to understand animal to human transmission and how we can better address these diseases that are easily transmitted through animal to human transmission is a very important part. Involving health as well as the other sectors will be important. Thank you.
Thank you, Dr. Fiona. The next question is coming to Dr. Lee, and this question is coming from Guy from Dakar Actu. As monkeypox is spreading in Africa and poses a threat to Senegal and other African countries, what measures is the country planning to implement to protect the population? Dr. Lee, please.
Oui, je remercie pour la question, je remercie l'intervenant. C'est vrai que le Sénégal, traditionnellement, n'est pas un pays endémique pour le monkeypox, pour la variole du singe. Néanmoins, nous suivons, bien entendu, ce qui se passe un peu au plan mondial. Et avec les collègues de l'OMS, nous avons déjà alerté, bien entendu, le système de santé. Et sur la base de documents partagés avec l'OMS à travers les bureaux pays, nous avons conçu des fiches techniques. Donc, nous avons partagé avec l'ensemble des acteurs du système de santé, lesquelles fiches techniques donc, décrivent un peu la maladie, l'épidémiologie, la définition des cas, les méthodes de prévention, les méthodes de traitement, en tout cas la conduite à tenir devant un cas suspect, donc les mesures d'isolement, etc. Alors, au niveau du centre des opérations d'urgence sanitaire, nous sommes placés en mode d'alerte par rapport à cette maladie. Et nous sommes en train de travailler, en tout cas nous allons le faire très rapidement, sur l'élaboration de plans de contingence spécifiques sur, justement pour le monkeypox. Par ailleurs aussi, nous avons fait le point avec les laboratoires en termes de capacité de dépister, de diagnostiquer cette maladie-là. Je pense qu'à ce niveau-là, on est assez tranquille, avec l'Institut Pasteur de Dakar et les laboratoires de l'IRSF qui est au niveau de Diamniadio, qui ont donc des capacités à diagnostiquer la maladie si jamais, en tout cas, on a des cas suspects. L'autre chose, bien entendu, c'est le renforcement de la surveillance. Donc, la surveillance doit être renforcée au niveau des points d'entrée, renforcée aussi au niveau de certains groupes, donc considérés comme les plus à risque. Ce que je peux dire, c'est que pour le moment, en tout cas, l'ensemble du système de santé est en alerte. La surveillance donc est renforcée. Nous avons les capacités de diagnostiquer. Il y a une question pour l'instant sur laquelle il faudra qu'on travaille avec les collègues du bureau de l'OMS, c'est par rapport à la question de la vaccination, justement, par rapport à cette maladie. Pour le moment, on n'a pas beaucoup d'informations sur cela, mais je pense que très rapidement, on va se rapprocher des collègues pour voir la pertinence de la vaccination. Est-ce qu'il y en a? Est-ce qu'il y a des vaccins disponibles? Quelle est, disons, l'efficacité? Est-ce qu'il y a des effets secondaires? Voilà. Donc, toute la documentation, toute l'information nécessaire par rapport justement à l'éventualité d'une vaccination. Voilà, et les stratégies justement à mettre en place si jamais on devrait peut-être aller vers cela. Donc pour l'instant, ce côté-là, on a encore besoin d'informations additionnelles. Mais sinon, sur le plan alerte, sur le plan préparation, le pays a fait ce qu'il faut, tout le système de santé est alerté, les fiches techniques sont partagées, la surveillance est renforcée à tous les niveaux et nous croisons le doigt, nous espérons que nous n'aurons pas de cas, mais comme la particularité de cette épidémie qu'on constate actuellement, c'est qu'effectivement, elle s'étend à des pays jusque-là qui n'étaient pas concernés par cette maladie. Mais nous avons pris les mesures nécessaires à ce niveau-là. Merci beaucoup.
Thank you very much, Dr. Lee. Yes, preparedness is key to early dictation. The next question is coming to you, Dr. Fiona, and this question is from Dorcas from BBC. For monkeypox, the number of suspected cases surpass confirmed cases. Why is this so? Morocco and Sudan were investigating suspected cases of monkeypox, according to Africa CDC. What is the status of this? Has the virus spread to non-endemic countries in Africa? Dr. Fiona, please.
Thank you, Dorcas, for that question. So far, the number of suspect cases, unconfirmed cases, is over 1,400 in Africa. And of these, only 44 cases have been confirmed from 5 countries. And indeed, when you look at the number of suspect cases versus confirmed, it's a large variation. And there are different reasons around that. Mostly, the capacities to be able to test and to confirm cases is one of those. As I mentioned earlier, we have only 10 countries currently with those capacities on the continent. So there is need to build up that capacity, but also the index of suspicion is high by nature of how monkeypox presents. So you will have a number of cases being termed as suspect cases because there's very similar presentation to others like chickenpox. So there is need to work around the health workers in terms of sensitization, in terms of training around the case definition for monkeypox, as we also work towards building the testing capacities on the continent. In terms of spread beyond the endemic countries, currently, we have only received reports to date of 2 countries outside those that are endemic, from Sierra Leone and from Liberia, of suspect cases in 2022. And these are still suspect. They do need to be confirmed. Samples need to be, they do not have labs in country. They need to have those samples confirmed as for us to include them as part of the confirmed cases. And really, I think it's promising that a number of countries are now getting alerted, and we expect to see more countries reporting suspect cases. Arrangements are in place to help and support countries to make arrangements for shipment of samples to places where they can be tested. Thank you.
Thank you very much, Dr. Fiona. We are now coming to the end of this virtual press briefing. So I will turn back to our panelists for their final words. I will start with Dr. Lee, then Dr. Adetifa, and Dr. Moyeti will round up. Dr. Lee, please, your final words.
Je vous remercie, Madame la modératrice. Je voudrais juste réexprimer tout le plaisir que j'ai eu à partager, à participer à cette importante activité, cette conférence de presse très importante qui nous permet d'échanger et de répondre aux questions, apporter des éclaircissements par rapport donc, aux participants, par rapport à la presse. Je voudrais remercier particulièrement Dr. Moyeti. Et je me permettrai de lui lancer une invitation la prochaine fois qu'elle viendra à Dakar, de bien vouloir visiter le centre des opérations d'urgence sanitaire, Madame la directrice régionale. Voilà, sinon remercier Dr. Adetifa pour aussi avoir co-animé un peu cette conférence de presse. Je vous remercie, Madame la modératrice, et je remercie toutes les personnes qui ont participé de près ou de loin à cette activité. Merci beaucoup.
Merci beaucoup, Dr. Lee. Over to you, Dr. Adetifa.
All right. Thank you very much again for inviting us to be part of this presser and to talk on the subject of monkeypox. I just wanted to use this opportunity to touch on a few things. I think we need to be in the situation with global health and the brokenness of it that was identified during the COVID-19 pandemic. We don't seem to have learned all the lessons that we need to learn from that. The narrative about monkeypox now, especially now that cases are being seen in other non-endemic countries, is again tending to follow some of the narratives that we have seen earlier. And I think it's important that we do all that we can to stop this. We're in a global connected world, and as WHO typically reminds people, is we are not safe until everybody is safe. In the local parlance we have is, of course, there's a saying that if you want to travel quick, you can travel alone, but if you want to travel far, then we all need to work together to assure not just our individual national health security, but global health security. And I think that is, what everybody should keep in mind, both countries in this case that are endemic for monkeypox and those that are seeing monkeypox for the first time. Thank you very much.
Thank you very much, Dr. Adetifa. And finally to you, Dr. Moyeti.
Yes, thank you very much, Mary. First, I'd like to thank all the journalist colleagues who joined us today, and very much thank my fellow panelists for having joined and shared with our colleagues all the information, knowledge, and what we are doing in 2 African countries to respond to the situations. Thank you to my colleagues who joined us as well to provide information during this press conference. I'd like to echo what was just said by Dr. Adetifa, that, for example, monkeypox may be something that some African countries may have become accustomed to seeing, and it was said the perception of risk at the level of the population is not very high. But we've seen with COVID-19 how viruses can change and the risk from them can increase. And I can only echo what I said at the beginning as well, that it's very important as we see such phenomena spreading to other regions, that we have a joined up global response, that if there are tools being developed, we make sure that we share those tools, we build capacity all over the world to respond to these outbreaks, because they can so quickly spread from one part of the country to the other, one part of the world to the other. And what I can say to our journalist friends, as you spread the information, please help us not to get back to the blame game as a dialogue as far as this disease came from here and it went somewhere else. We're very much a connected global community, and we need to continue to work to address such problems in that way. And then finally, just a word about the COVID-19 pandemic. We've said we've seen a small spike in South Africa. It was brief. The peak was lower than the previous spikes have been, but we need to continue to vaccinate and booster those people in our region who are particularly vulnerable to severe illness and to death. So I'd like to encourage all the elderly people, people with the diseases and conditions that we mentioned, please come forward, be vaccinated. Countries are working, governments are continuing to work very hard to get the financing to continue the campaigns so that we reach a level of coverage where we can, in African countries, then be comfortable that even if the vaccine is spreading, and we've seen in the surveys that have been done that the exposure to the virus has been quite considerable in African populations, we must make sure that those who can get severely ill and die from COVID-19 are protected. And then I'll end. Merci beaucoup, Dr. Lee, pour l'invitation. Bien sûr, je viendrai vous rendre visite la prochaine fois quand je serai à Dakar, et je crois que ça sera dans les 2 mois à venir. Donc, merci. And again, thank you, my fellow panelists, and we continue our work on the African continent. Thank you, Mary.
Thank you very much, Dr. Moyeti. And now we have come to the end of the press conference for today. Thanks to all the panelists, and thanks to our experts, and thanks to you journalists for the good work you're doing in making sure that the right information is out there to the general population. Thank you, and I wish you all the best for the rest of the day. Have a nice day.
Thank you.
Bye.
Au revoir.
Au revoir.
Au revoir.